Surakshit. Yeah, Dr. Talat here.
Hi, Dr. Talat. How are you?
I'm good, sir. How are you?
Doing good, doing good.
Yes, sir. So
Yeah.
after the technicals finish, we'll be starting in a while.
Okay, perfect, perfect.
Yes.
So you're working with Metropolis, is it?
Yes, sir. Yes, sir. Since 2017, I'm associated with Metropolis.
Oh, that's so nice. Okay.
Yes.
I met you. I didn't see you in Chennai for the MedEngage program.
Yes, sir. Yes. Actually, the MedEngage team along with the officials had gone. So
Yeah.
yes, sir.
Okay. There was another doctor there, no? Dr.
Dr. Kirti Chadda.
Yeah, Dr. Kirti was there. Yes, I
Yes,
remember.
yes, yes.
Yeah, yeah.
So yes,
Yeah.
Chirag.
So sir, everything's fine. You can stop the screen sharing for now.
Okay, 1 second. I also want to see if my presenter mode is working, no? Please hold on.
No, sure, sir.
Yeah, 1 second. Okay. Now, how does it show on your? So, is it in the presenter mode or is it in the regular mode?
I can see it in the presenter mode, so I guess you'll have to share it in the normal way itself. Yeah.
Perfect, perfect. All right, all right. Okay, so I'm going to stop sharing this screen for now.
Yeah. So sir, it was shared in the presenter mode itself. I could see that as well. So
Okay, so I will just put from like as
Yeah.
slides only.
the earlier way. Yeah.
Yeah, I'll do that. I'll do that. Or is there any other option here? Let me just check it once.
Sure, please.
I'll just stop the sharing and restart it. Whiteboard layouts. I think as I don't believe they have that option. Again, it's in presenter mode. Is that?
Yes. So it's better if you just
Yeah,
change
sure,
that
sure.
option only.
Yeah, I will do that. I will put it as a regular show.
Okay.
Yeah.
So Dr. Talat.
Yes. Hi.
So I believe everything's ready. We are about to start. So request everyone to be on standby, please. So I'll just switch on that video. Currently, we are playing that video, Dr. Talat. Once you see yourself in that screen, you can start the session.
Perfect. So good afternoon to one and all. I, Dr. Talat Khan, welcome you all to yet another exciting MedTalk session by Metropolis Foundation on the topic, the art of assisted reproductive techniques. Assisted reproductive techniques are the technique which assist the infertile couples to conceive babies by various medical methods. It has been the topic of discussion in various medical forums as an ever-evolving technique and due to the recent changes in the art law. Today we have invited Dr. Surakshit Battina for this topic. Dr. Surakshit Battina is a highly skilled fertility specialist, laparoscopic surgeon, and a cosmetic gynecologist with expertise in advanced surgical techniques. He has done his fellowship in reproductive medicine from UK and is the founder of Indigo Women's Center at Chennai, India. Dr. Battina has performed the world's first documented laparoscopic management of uterine rupture. His focus on delivering high quality care to the patients and furthering the boundaries of gynecological medicine. Today, he will be shedding light on a very important topic, highly relevant in today's scenario, assisted reproductive techniques. Over to you, sir.
Thank you so much, Dr. Talat, for this wonderful opportunity. And I would also like to thank the whole Metropolis team to having involved us and having such programs. I think it's very beneficial for all the students and also upcoming gynecologists. I believe it's right information, and also big kudos for the whole MedEngage team to do for doing such a fantastic job on all our events. So anyway, thank you all so much for having me for this presentation. I'm going to start off with the presentation. Can I share my screen now?
Sure, sir.
Yeah. Okay. Is my screen visible?
Just give us a second, sir.
Yeah, yeah, sure. And I really like the whole, the wording, the art of ART, where ART stands for assisted reproductive technology. And I will be showing you the whole journey of where we started and in which direction we are moving towards. And you will also find that the journey, when it started out, also was quite fascinating, and where it's going, it's even more fascinating. So I think once we start the slides, I'll be able to explain to you more in detail.
You
Yeah,
can start, sir.
perfect. Thank you so much. So yeah, the talk again today is about the art of ART, and I was already given a brief introduction about myself. I have a lot of experience in fertility medicine and cosmetic gynecology and reproductive medicine. Of course, I'm also a laparoscopic surgeon. And I cannot talk about ART or assisted reproductive technology without showing this beautiful photo of this family, where you can see this young girl. She was the very first baby to be born from IVF in 1978. So, after she was born, imagine her sister, when she was born, she was the 40th baby to be born through IVF again. So that became so popular. Initially, we were considering this as to be an experimental procedure, and today we consider it as the biggest breakthrough in medicine in the 21st century. And of course, after she was born, there were 40 other babies before her sister was born. So you can imagine how quickly it took off. The reason why this IVF was done for this woman was because, she had blocked fallopian tubes. Now we have like 100 different reasons of why we do IVF for, but that's where we started off. This is today's picture of Louise Brown, and that is with her two children, both of them conceived naturally without the need of any IVF. So I think the technology is only required once, and not after that. No, it's not something that actually goes through one generation to another. Coming to some of your statistics, what we need to understand in India is that 10 to 15% of them, of all married couples, are affected by infertility. And out of these 10 to 15%, 40% of them are the female factors, 30% of them are due to the male factors. When you see 10 to 15%, you might think it's a small number, but it's around 27.5 million couples who are suffering from infertility in India alone. Okay. And out of this 27.5 million, guess how many people go for treatment? Only about 1% of people actually seek treatment in India. So, which means there's a lot of space, and there's, of course, a lot of growth and a lot of need for also infertility specialists in India currently. So, you will ask me this question, why is infertility on the rise? If you ask me, the main reason is always stress. Okay. It can be either due to work or it can be because of social media. And if you look at it, you know, uh, I would say social media, they might say that how is that a stress? You see, this thing called as doom scrolling. The more and more and more you scroll, the more anxious you become, the more, depressed you become. And in fact, it has seen that, in current societies, the amount of anxiety and depression has become very, very high. This is due to social media. And of course, that caused a lot of stress. And of course, you have the smoking and drinking of the pub culture which is going on. That also is quite unhealthy. People nowadays, you see the number of restaurants outside, every street has maybe around 10 to 12 restaurants. Unhealthy eating diet habits have also taken a big toll on our fertility levels. If you go to Delhi anytime, I don't have to tell you how toxic the environment has become. It's so smoggy over there. Environmental toxins also play a very big role in this. Women nowadays, of course, they want to delay their childbearing because, they have other career plans. They want to do, more in their studies. They want to keep climbing up the ladder. There are certain options which are available for them, which I will be discussing also in the future slides. But because of delayed childbearing as well, the infertility rates are going up. And of course, the sedentary lifestyle. We're not as active as how our ancestors were, before they had to travel by, cycle, or they had to walk for long distances. Now we have cars. We are more sedentary and more, luxurious lifestyles we are leading, but it is also causing a lot of infertility. Now you're looking at male issues also. There is an increase in sexual dysfunction. The number of men who come into my clinic saying that they are unable to, have erection, they are unable to have, they're having erectile dysfunction, they're having premature ejaculation. These numbers are also gradually rising. Again, due to various factors, what we've spoken about before. And also, there are some abnormalities in the sperm parameters. I will show you another slide also. Next, you will understand how bad the situation is actually at this point of time. And there's another condition, which is the nil sperm, which is there are no sperm at all in the sample which they're giving. And this again is a problem nowadays. Look at this WHO trend. From 1973 to 2011, there's a 52% decline. 52%. That's a huge number. Decline in the sperm concentration and 60% decline in the total sperm count. Okay, so when I started off my, MD, I mean, before I started off my MD, the normal sperm count was somewhere close to around 30 million. Now, today, the normal sperm count is around 15 million. So you can understand like the gradual decrease of the sperm, year after year, decade after decade, and it is really going downwards. It's in a downward spiral. You can see this is the current parameters today. You can see the volume is 1.5 ml, which is fairly okay. It has been the same. Concentration is around 15 million per ml. It's not 16. Total motility, they expect around 42%. Out of them, they want the forward moving, rapidly moving ones to be around 30%. That is the sperm. And normal morphology, you can just look at this number. 4% we consider it to be normal today out of the 100% of sperm which are available. So that is where we stand. Coming to female factors, women are having a lot of ovulatory disorders. Again, I told you because of the unhealthy lifestyle and everything else, women are having PCOD. I would say around 80% of women who are coming into the hospital today have some kind of PCOD, right? Women are having also this new condition called as the premature ovarian failure, wherein, beforehand itself, usually women hit menopause around 50 years of age, right? These women who have premature ovarian failure, they hit menopause at 30 years of age itself. Why this is so is because they rapidly lose all the follicles or the eggs much before they hit menopause, and because of which infertility levels are on the rise. Then you have tubal factors. These have always been the same, but because of TB and other conditions being more prevalent in India, tubal factors are more in India. And of course, tumors in the ovary, uterus. There are 50% of women in the world, whole world, have a fibroid, which means one out of every two women has a fibroid. If that is the case, right, only where, if they are situated in locations which causes problems and infertility, only then they need to be treated. Okay, I will be telling you about that as well soon. And of course, we have the unexplained infertility. When doctors don't have any answers or they don't know why you are infertile, they just say it's going to be unexplained infertility, which amounts to around 10% of all the infertility couples, right? Let's talk about our treatment options. Men who have low sperm count, that is somewhere near the average sperm count of around 15 million, maybe it's around 10 million or maybe it's 12 million, you can give them antioxidants. So these are the only known treatment available right now for men to hopefully improve their sperm count by reducing the oxidative stress levels, right? The other way of how we can do or we can bypass this if the couple is looking for pregnancy is that we process the sperm, separate the good sperm from the bad sperm. The good sperm alone, we make it into a tiny pellet. We feed it into a small thin catheter and push it directly into the uterus. So the sperm doesn't have to go from the vagina through the cervix to the uterus and then into the cavity. We directly push it into the cavity. So this way, there is more amount of sperm which is inside the uterus for the availability, sorry, where there's more sperm available in the uterine cavity for the sake of fertilization, right? Now, what if there is no sperm? I told you, there are conditions where there is a semen sample, but there are no sperm in the semen sample. In that situation, we can directly aspirate the sperm from the testis, the process called as TISA and MISA, wherein we just inject the testis and directly take the sperm, and that sperm, what we retrieve, immediately we will be using it for a process called as ICSI, which I will be explaining to you what exactly it is in the next slide. Right. Women with anatomical causes. I told you women have fibroids, right? The moment you realize that, it's in a position where it can cause her fertility or it is causing her a lot of pain and a lot of discomfort, at which point you can go ahead and do a laparoscopic procedure. It is a daycare procedure. She comes in the morning, by afternoon, she's able to go back home, and we retrieve or we remove the whole fibroid mass. And then after that, we give her 3 months gap, and then she'll be able to, conceive naturally, provided all other factors are normal. Now, what if women are having ovulatory disorders? Well, of course, we have options. We can do an ovulation tracking. You ask the woman to come from the 12th day through the 16th day of a menstrual cycle. These are usually called as the fertility windows of a woman, isn't it? So this is the time when one of the follicles are going to be released. And during this time, what we can do is we can track the ovulation by doing an ultrasound scan, and we will know exactly on the day which day the egg is released. And on that day, we will inform the couple, okay, you be together today, so you have a good chance of pregnancy. We also have ovulation induction medications where we go ahead and we give a single, tablet for the patient from the 3rd day onwards to the 7th day, so as to release, at least one egg, to force the release of one follicle. We also have super ovulation, where we give the women injectable medications so as to get not only one but a few more follicles, so as to improve her chance of pregnancy. So how we do it is to improve her maximum chances per cycle, the fertility rates per cycle for a woman, is that we combine super ovulation along with an IUI to give that couple the maximum chance of having a pregnancy in that cycle. Then, of course, if that doesn't work, we go in for ICSI, also known as the intracytoplasmic sperm injection, where we inject a single sperm. After we find all the single nice sperm in the whole sample, we take that and we inject it directly into the egg, and we make the pregnancy outside. Okay. And then once we confirm that the, fertilization has occurred, only then we will transfer the embryo into the uterus. Okay. That's what ICSI is. Now, imagine for ICSI, previously we used to have these very long protocols. That means you have to start from the 21st day of your previous month's menstrual cycle, take it all the way to the 14th day of your current cycle. And at that point only, we will be able to get all your eggs outside for, the process of ICSI. But thanks to modern medicine, thanks to advancements, now we have the short cycle, also known as the GnRH agonist cycle, where we start the GnRH antagonist cycle. We start the stimulation from the 3rd day onwards, and by the 12th or 15th day, the whole cycle is over. The whole retrieval of the follicles are over. In fact, even the fertilization is over in the same cycle. Okay, so this way, something what used to be a very long and tedious process before, now it has become a very short process. And in fact, even more better, at the same time, they're able to retrieve more number of follicles for a woman in an even more shorter period of time. For example, they're doing two retrievals. It is called as a dual stimulation. They're retrieving both in the follicular phase of the menstrual cycle and also in the luteal phase of the menstrual cycle. So that also is a possibility nowadays. Of course, this is for women who are traveling or who have a very limited period of time, or they have very less number of follicles. These advancements of stimulation protocols are being followed. Now, initially, what we used to do, we used to transfer the embryo on the 3rd day only, because you cannot culture the embryo outside the body for too long, isn't it? Maximum they were able to culture is for 3rd day, and after the 3rd day, they were able to transfer it back into the uterus. Now, thanks to advancements in these culture media as well, we are able to take it all the way to the 6th day. So what does that mean? If in case the patient is having, is able to have, I'm sorry, if the embryo is able to develop for 6 days outside the uterus, then when you transfer it on the sixth day, it should have a much more higher potential to implant when it is transferred inside. So nowadays we are only doing blastocyst transfers so as to tell, yes, it will definitely have a better success rate after implanting the embryo. Rather than doing a day 3, we do a day 6 because day 3 chances might be much lesser than a day 6 transfer. Okay, I hope that part is clear. And to make things even more better, we are able to beautifully see how these embryos are growing for the past 6 days. And the ones and it is shot like a very nice movie. Okay, you can see that this is called as a time lapse technology. This has recently come up and it is being used by a lot of hospitals where they see the ones which are growing in the very nice and uniform pattern, and that embryo has a higher likelihood of implanting inside the uterus, and that embryo alone we are using. See, these are ways how the technology has been improving. So from day 3, now we are at time-lapse technology to improve our chances of pregnancy every cycle. You want to increase the chances even more. You have prepared the seed. The seed is ready for the implantation. Now think about the soil. You want to make the endometrium also ready for implantation. Of course, while you're giving a lot of medications in that particular cycle, the woman's hormones are going to be all over the place. So then what we do, we stop all the medications, we freeze the embryos. Okay, we freeze the embryos, and after that, the next cycle, we do something called as a frozen embryo transfer, where we only prepare the soil. That is, we only prepare the endometrium of the patient, and that frozen embryo is thawed, and then it is later it's later placed inside the woman's uterus. And the other advantage of frozen embryo transfer is if in case a woman is traveling, or if in case she's having some function in the next month and she has to attend it, at which point also you can freeze the embryos for however long you want. I've known women who have frozen their embryos for close to 20 years and then had their transfer done later. So that is also possible. Okay. And yes, also there's another way to make sure you can test the soil to make sure it is also okay. This is called as the ERA, or the endometrial receptivity assay, where it's a genetic analysis of the tissue we take from the endometrium and we process this, and then we get to know whether this endometrium today is going to be receptive or non-receptive. The more receptive it is, the higher chance of us to have an implantation positive pregnancy. A positive implantation for pregnancy. You tried everything, nothing is working, maybe because of the age of the woman, or you don't have enough number of embryos. What is our next step? We can go for egg donation, where the egg is taken from a donor. It is fertilized with the sperm of the husband. The embryo thus formed is going to be transferred into the mother. So this way, the chances of pregnancy is going to be much higher. And this is because, most of the times, if there is some kind of issue with the egg, or if there's some problem with the quality of the egg, or the age of the woman is very high, then of course her chance of implantation is going to be low. But when you use a donor egg, of course, the donors are going to be much younger. So the chance of pregnancy also is going to be higher. Because again, in all of this, the highest chance of pregnancy for any couple only depends on the age of the couple. Okay. Now, imagine if donor is not an option for the woman. She is like, no, no, doctor, donor is not an option. What are the options which I have? Then, of course, we have the stem cell therapy, where we retrieve the stem cells from the woman's bone marrow. We process these stem cells, and we inject only the concentrated stem cells directly into the ovary by through a laparoscopy. Okay. We have tried this for a couple of patients, and surprisingly, we had a woman who had very, very low AMH. AMH is the value which is going to let us know what are the quality of the eggs and what is the quantity of the eggs what we can get from an IVF. So our plan, because she had very low IVF, was to give her the stem cell therapy, and maybe 2 months later plan for an IVF for her, maybe 2 to 3 cycles of IVF, so we get a good number of follicles which we can transfer in later. But to our surprise, in 2 months' time, she calls us back and she says, Doctor, I conceived naturally. So this also is a possibility, through stem cell therapy, through stem cell therapy. But unfortunately, we still cannot recommend this as a main state therapy because there is a lot of question marks. Like, how often should you give stem cell therapy? Is a single dose sufficient? Or at what intervals we have to give it? So there is no standardization. And, we do know that there is a proper benefit from it, but we still don't know on how to standardize it. So there's a lot of research and work going on in this therapy right now. Of course, I wanted to talk to you about fertility preservation. Preservation. What about women who want to delay their fertility for a later date? They don't want to have become pregnant now because of various reasons. Maybe she wants to conceive much later. At which point they can go ahead and freeze their eggs. Okay, this is called as the egg freezing or the oocyte cryopreservation, where we freeze all the eggs and then she can get them. Transferred at a later date. It is more like an insurance policy, isn't it? We all don't need it, but if in case at a later point you need it, it's always there. She maybe the woman gets married later, and then she later realizes that she's not able to conceive. Then she always knows, yes, I have those embryos. I mean, I have those eggs ready, and I can always get them transferred whenever I want. So that is also a very empowering option for many women today. And of course, I don't want to go into immunology because that is a whole different horse and a whole different topic altogether. There are millions of things which are going to be done in immunology. In fact, the future is only going to be two things you're going to listen to: immunology and AI. Okay, so with these two things, right, the whole reproductive medicine is going in a very, very, very fast and at a seriously high rate, where basically the chances of implantation and the rates of implantation, the embryo quality, each and every single thing is being monitored by the AI. Okay, it is going to tell you which exact day you should do the embryo transfer, which exact day you should do the stimulation. Everything is going to be guided by the AI in the future. Okay, I don't think even doctors will be necessary at that point of time. We just need to give the injections for these patients. So that's how the technology is moving, and it's moving very, very, very rapidly. So definitely, I think going into the future, you should keep an eye on this technology because, I don't see any other way. I think it's going to be inevitable. So that concludes my talk. I hope if you have any questions, I'll be able to take them now. Thank you.
So, sir, we have one question in the chat board. Elaboration on transportation of embryo biopsies or embryos for diagnostic testing in India and in abroad. Like in
Yeah.
what temperature, the logistic challenges with respect to embryo biopsies.
I think there's embryo biopsies have been done. I don't know if there's a logistical issue. I think there's only a problem with the the laws in certain areas. They might ask you not to move embryos. For example, there are certain laws where you cannot transport the embryo out of a certain country, and it all depends from one country to another. But in terms of transportation, it's very simple. These things can be cryopreserved and they can be sent to wherever, whenever. You can see they are very crude and very old-fashioned, and I don't think there's any logistical challenge. But of course, whenever you have to move containers, you cannot really maintain the same temperature throughout. It has to be moved from one container to another. So there's of course that little bit of variability. But I think when you're looking at the large scale, it has to do more with, the permissions of the particular country and their laws rather than actual logistical issues.
Okay, sir. So one question we have on menopause actually,
Yeah.
when we were discussing about premature ovarian failure. So action points for females to delay menopause, considering lifestyle and hormonal changes.
Yeah, I think menopause is pretty set. It depends only on the number of follicles what you have in your ovary, isn't it? Every woman is born with a
Yeah.
million follicles. They slowly keep depleting them. The rate of depletion only decides on your genetics. So if in case your mother had a early menopause, it's quite likely that you will have an early menopause as well. So it all depends on your genetic makeup rather than thing. But of course, if by chance you hit menopause, then there are a lot of things you can do to avoid menopausal symptoms, that's completely a different topic. But I don't think there's any way you can delay your menopause because your rate of follicular depletion only depends on your genetic makeup.
Okay, sir. Exactly. So there are no more questions that I can see on the chat board.
Perfect. Perfect.
So it was a very nice interactive session, sir. So it was very enlightening also to know about the knowledge about IVFs in brief.
Yeah.
I know it's it's like a vast ocean and it cannot be contained in 1 hour of discussion. But then, of
Yeah.
course, you have touched upon all the important aspects of IVF and
I just
assisted
wanted,
reproductive
yeah.
techniques. So,
Yeah.
on behalf of Metropolis, I'd like to thank you for enlightening us with such an important topic. We will, of course, be happy to interact with you in future as well. Thank you.
Absolutely. Thank you so much for having me. Thank you.
It's closed now.
Okay, thank you. So, thank you, sir. I think we can log off then, Chirag.
Yeah, thank you. Thank you so much,
Mhm.
Chirag. Thank you so much, Dr. Talat. I think it was a nice session. It went on well. Yeah, can we have any idea about how many participants were there? Or
So it will take some time to generate the
oh
log.
yeah, perfect, perfect. And will this be aired also on YouTube?
So yeah, we were streaming live on YouTube.
Okay,
So you
okay.
can find that on a Metropolis Labs page.
Oh, perfect, perfect. All right. If I can get any link, no, I can share it with my colleagues as well.
Sure, just give me a second. I'll share the link over this chat.
Yeah, perfect, perfect. Yeah, got it. Thank you so much.
Okay,
Have a
thank you.
good day.
Have
Yeah,
a good
thank
day,
you.
sir. Thank
Yeah,
you.
take care. Bye, bye. Thank you.